Let's, again, take them one at a time. The expansion of coverage really causes the amount of expenditures to actually go up in the short term. As I said, it's somewhere around $1 trillion. The House bill is estimated to be $1.042 trillion. The Senate is desperately trying, the Finance Committee, to get the cost under $1 trillion. But what are the considerations as to how to pay for this? Where's the money going to come from? And the clues we have are from the budget that President Obama offered and also from the current tri-committee bill in the House. And I'm going to very much oversimplify here, but basically half of the cost are deemed to come from savings in the existing Medicare and Medicaid program. Or another way of saying it, they're going to come from cuts. The largest piece of this is the elimination of the Medicare Advantage program. That's a detail you probably don't care a lot about, except you hear the president refer to it all the time. He talked about it twice in the recent town meeting. The Medicare Advantage program, simply stated, was a program by which the federal government outsourced Medicare to private insurers, and at least according to the administration, they've ended up costing more than traditional Medicare. The president quotes the number of $170 billion are being paid out of taxpayer dollars to subsidize this Medicare Advantage program to private insurers. So he says we're going to get rid of that. And then there are additional cuts to hospitals and doctors in the Medicare program that are being proposed to help finance this. Now clearly that's a concern because I've already told you they pay us below our cost. But legitimately and fairly, and I want us to be there, is as we expand coverage, clearly there are some cuts that the healthcare delivery system can absorb because we're going to get paid for people that we historically haven't been paid for. So it's important to be fair about this. And so, again, half of the proposed financing of the short-term increase in coverage is done by changes to the existing federal government programs. The other part in the House bill is being paid for by imposing a surcharge on families with incomes over $350,000, individuals over $280,000. It's about 1% up to $500,000, and then when you get to an income of over $1 million, it ends up being a 5.4% surcharge. It's a pretty significant tax. Stated simply, if we're honest, it is a tax on the wealthy. That's how the rest of it's paid for. Now that proposal, particularly the surcharge, is only in the House bill. It's already being controversial. I will tell you, it likely will never get Senate approval, that shift in putting this on the wealthy. So on the next slide, what you're going to see is a list, and it's not a complete list, of all the other proposals that are being put out there to pay for reform, but really have not firmly made it into a bill per se. And I'm not going to dwell here, but I want you to look at a couple of them. The most productive change in terms of dollars is placing a cap on the exclusion that we currently have from taxation on our health benefits. Anyone who's employed and has a health plan, that's paid for pre-tax now. It's excluded from being taxed. It doesn't matter how rich your plan is. You can have a plan that costs $20,000 a year and you still get it pre-tax, or you could have a much more modest plan and it's pre-tax. So many are saying, we're not going to eliminate the tax exclusion. That would probably create public revolt. But place a cap on that. And if you do that across the population, there are estimates that could exceed $400 billion over 10 years. That gets you a long way toward $1 trillion. Others say, well, I want to cap it, but only for high earners, and that gets you, obviously, only $162 billion. You'll notice on the rest of the slide there are a lot of sin taxes. The Obama administration is very much wanting to promote healthiness in this country, so let's further tax cigarettes, let's further tax alcohol, and there's an interesting 3-page part in the Senate Finance Committee document about taxing 12 ounces of sugar-sweetened beverages. It even gets down to defining sodas versus fruit juices. The idea, again, trying to deal with the obesity program, particularly with children. I mean, it's not at all irrational. But the point is, somehow, out of the combination of all this, cuts and revenue, you have to get to $1 trillion. And quite frankly, I think what's going to emerge, regardless of what bill makes it, is going to be some combination of cuts to the existing programs or reductions and some additional revenue in some form of tax or elimination of tax exclusion. This is not easy. It is no wonder it's a source of heated debate, particularly in the present economy. That's just the short-term cost problem. What are we going to do with this long-term trend? How do we begin to curb that, and what is the administration planning to do to address that? Again, with the danger of way oversimplifying, I at least want to point out three major focus areas. One is they want to rely on efficiencies emanating from a great investment in information technology, especially accelerating the adoption of electronic health records across the country. In fact, the Obama administration put $20 billion in the stimulus plan to help promote the adoption of electronic medical records. Second is a huge new investment in prevention and health promotion. The concept here, if we have a healthier population, and particularly if we can do screening up front, we'll avoid cases getting into complicated and costly cases and therefore save money over the long run. And third, and a major area of long-term savings, is reforming the existing payer system, the way providers, such as hospitals and doctors and others, are paid. Simply stated, this is moving the payment system away from paying providers just for doing more, and instead redesigning the payment system, realigning the incentives to pay for outcomes rather than for just quantity. Again, that leads us immediately into our third bucket, health system delivery reform. Now, the focus here really is on improving the system, its effectiveness, creating efficiency, enhancing quality, creating some consistency across the country, because we know factually that for the very same case, it cost more in Miami than it cost in San Francisco. We need to figure out how to create some consistency, even some kind of standardization in terms of what it costs by following best protocols across the country. The quote on the screen is very telling. It is the preamble to the Senate Finance Committee document on financing of health care. And just look at what it says. Today's payment system rewards providers for the quantity of care they provide. You get paid every time you do something. You get paid more if you do more. Instead, we want to realign and reorient the incentives toward that which improves care. The intent here, therefore, is to reward providers for effectiveness rather than for volume. Now, payment reform, to say the least, again, guess what, is very complicated.